Have you ever considered starting your own practice? Where do you even begin? And why is it so important to get a line of credit instead of a loan? Listen and you'll find out from private practice neurosurgeon Brian Gantwerker from Los Angeles, and he may inspire you to quit your practice and go out on your own.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. And now, here's Dr. Bradley Block.
Dr. Brian Gantwerker, thanks so much for being on the podcast.
It's my pleasure. Thanks for having me.
So you, from scratch, started your own practice, right? From nothing, as opposed to me, who just joined a well-oiled machine of a private practice, right? I never had to start anything. So this terrifies me, this whole idea of like starting from nothing. So what made you want to take that plunge and just go, I'll just start something from nothing?
Well, that's a terrifying thought, and especially if I transpose myself to today's market and climate. I think that'd be very, very difficult to do it again. But I'm seeing some folks do it. It goes back to I was about halfway through my first year with my first job, and my wife, who's from California, used to run a orthodontics practice in Santa Monica. And we were living right next door in an area called Brentwood, and still live there. About 6 months in, I was sort of not really enjoying myself. I wanted to obviously finish my contract out and do what I had to do. But I had this strange notion of going and sort of just hanging my shingle up. I'd never run a business before. In fact, I had zero business experience, I had zero economics, finance courses in all of college, medical school. I knew nothing about starting a business. So we were just talking about it, and we wanted to do something our way in terms of like the high patient contact and sort of just doing the cases that I'd like to do and being closer to home. And I just seeing no opportunities at the time, I decided to create one. So I got a lot of inspiration, I think, from my grandfather, who used to work for a very large insurance company, Mutual of Omaha, and did very well there, and then decided after many years that he was just going to start his own practice, hang his own shingle. But he didn't really give me anything other than the inspiration to do it. During residency, we had a couple of guys who were private practice and had joined the academic practice, but told me of the days when dinosaurs roamed the earth, and I just had the audacity and perhaps the idiocy to think I could do it too. I will tell you, I got a book on how to start a corporation, and I started talking to some people in the community outside of my general specialty, which is neurosurgery. And I remember speaking to a plastic surgeon who was at an engagement party with me, and his name is Joe. I said, Joe, I want to do this thing, but I don't know how to do it. And he just put his hand on my shoulder and said to me, Brian, just hang your shingle and the patients will come. And so we started out, we got a business license, I got a line of credit, and we got our Medicare signed up and got some contracts going, and we're subleasing space. And we just started. I was on call, taking call a lot, getting patients that way, but ultimately doing a lot of hand holding and pressing of the flesh with referring doctors. And then it just sort of started to really slowly sort of pick up lint, so to speak. If I were a giant Velcro ball, I kind of liken it to like picking up lint. But really, as it happened, when you are in a community, even a big one, you start to distinguish yourself. People start knowing your name, hopefully in a positive way, not in a bad way. But if you start to distinguish yourself, you're doing good work, you'll get those phone calls and those referrals. So I think the main thing about starting is just to have the idea that you're going to do something not totally outrageously crazy, but you're going to do something that will distinguish you from the other ones. And then for us, it's a number of things, but you have to really think you could do it. And I think that's the first thing, is you have to think you could do it. And we
So
just
there were
went all
some
in.
details. There were some details there that you kind of glossed over. First, you're like, oh, and then, we got our Medicare, or you got accepted under Medicare, and then you got on some
Hmm.
commercial insurance panels,
Hmm.
right? And that takes forever, right? Like when I joined my practice, they were like,
Hmm.
I was still, I guess, a resident. They were like, you got to fill out the paperwork now. And I was like, I can't, I don't have time. I don't have time. I'll do it when I have all this time when I'm done. And then I
Hmm.
did. And then I wasn't on any panels when I started. I was in
Hmm.
zero because
Yes,
there was no lead. This stuff takes months. And
it
meanwhile,
does.
what are
It
you
does.
doing in that time other than burning cash?
You are burning a lot of cash, and that's what it was kind of terrifying for the first couple of months. I was on a call panel. I stayed on that call panel for a little bit, and just because of different reasons, that I ended up going off that panel, and I started on a different panel. And I just started. It was actually the panel at that time was not paid for. It was just, but it was in a very good pair mix. So we started. I started. I actually ate into my line of credit quite a bit, just to sort of do things. But I think it's also about controlling costs. I mean, a quick story, when I started and I broke out from my first group and I started my Medicare process, we had a billing company. The billing company started my application through something called Paycos at the time, which is an online application for Medicare, but there was a hiccup and the Medicare got caught. And I started seeing Medicare patients and we couldn't move beyond that little hiccup. In fact, I had to involve my congressman, my actual congressman, who I'm still friendly with, in order to push this through. And there were no problems, right? There were no issues with Medicare. But this is an example of, you said there were delays, and this was a supreme delay. In fact, I didn't get paid by Medicare for almost 3 months and nearly ruined us. And in fact, one of my patients came up to me and said, it was actually her husband said, "Why are you not billing? Why are you not billing Medicare?" He said, "I got this EOB and you haven't billed them anything." I said, "Because our number is not kosher yet. It hasn't gone through." And it became almost an act of Congress. So you kind of have to be ready to not have that cash flow. And when you're first starting out, being able to sort of figure out where your cost containment can be, but you're going to eat into whatever reserves that you have. And let's not forget the time we were trying to get pregnant, we were paying for IVF. So you think about all those things going through, the incredible stress and strain. And we're not wealthy by any means. I mean, at that time especially. Um, but you have to be prepared for things to be very, very slowly, and you have to be strategic. And I would have to say, if you're going to do it, make sure you're in a good payer mix, and that your Medicare gets started early, and just be very, very persistent. I think you have to be persistent. But really, getting contracted with insurers does take a couple of months. But the main thing is just you have to be superb and persistent, and you have to still do a good job in surgery. And eventually, you'll be able to bill for those things even 6 months in arrears for most commercial insurers. And I think it's still a year for Medicare. So if you did something in February of 2021, you could still bill at that time, I think, from a year hence. So you will get scary, and your reserves may run low, but you need to just strategically plan your costs and where you're going to be. And it's, mastery of that revenue cycle is probably still what's taken me almost 11 years to figure out, or sort of the ebb and flow of the payers coming in and coming out, and also the delays in getting paid. And I just think what you have to do is, first off, get yourself on a call panel, even if it's not paid. Hopefully it is paid, but if it isn't paid, make sure it's in a good pair mix. If you're in a call panel, make sure you're getting your stipends, and stay on the person who's supposed to be submitting at the end of the month. Usually it's going to be like a director of the department or the head of the department, who may or may not be in your group with you. So you have to stay on top of that, because your stipend will kind of float you until you can get those insurances starting to flow. And just keep an eye on your credit card, keep an eye on your expenses, and just try to leave some cash in reserve if you can. But it does get scary. But having a line of credit, that's kind of where it goes back to. Having a line of credit is really important, because if you take an SBA loan, it's a one-time thing. And once it's paid off, that's it. A line of credit is revolving, and it allows you to dip and float, dip and float. And that's what was really important for us getting started in the beginning.
Yeah, makes sense. Like
Hmm.
you get on a panel, and then you're able to back bill all the stuff that you've been doing,
Hmm.
and
Yep.
then you can pay down some of that line of credit. Well,
Yes.
then that's good for a little while, and then you're gonna be taking out more money again. And then, so those ebbs and the line of credit helps you manage those ebbs and flows.
It helps get you through those ebbs and flows. And it's very important that you bill properly and accurately so that you don't get in any trouble with anybody. I've heard stories about people being encouraged to bill or upcode by their employers, not their private practice, but their employers, asking them, well, document the patient had sepsis or something when they didn't. So it's very important. It's very important. And I had someone come up and sort of ask a general question. We had a coding course, and this young person was maybe a year or two into their practice, and they were an employment practice. And the coders for the hospital were coming up to the person and asking them if they could code that the patient had sepsis. And he asked this coder person, if that was okay. And I said, if you don't look good in orange, I mean, it's not a good idea if you don't look good in orange. So I said, it's not worth it. I mean, the important thing is bill accurately, bill timely. Timely billing is very important. So you got to make sure you submit your charges once a week, set aside a day. Like I do it every Friday, or I try to do it every Friday, where I submit the week's worth of stuff that I've done in the hospital or in the ASC. So you have to get used to, you have to be regimented in sort of getting your coding in, getting your billing in. And also, if you have to dip into line of credit, it's not the end of the world, but you just have to get a feel for it. The first year or two, or sometimes even 3 or 4, can be really scary, but it's doable. But you have to be able to build business as you're going. So it is a bit like my wife likens it to a hamster wheel. So it's like you get on the hamster wheel. You just have to be prepared and get yourself fit enough that you can get through the hamster wheel, and know when to jump off it too is important too.
So then I guess you're kind of the exception, but the next question would be, who do you hire? I guess in your case, you're looking for a significant other, right? But for those of us who have a spouse who doesn't do this, who is the first person that you hire?
The first person you hire is usually someone who has a lot of experience in the field. So someone whose this is their first job in medicine, it's not a good hire. The biggest difference you're going to tell between a practice that's probably going to do fine and a practice that is sort of going to be very reliant on, sort of captured contracting, are going to be the way that the staff comports themselves. And what I mean by that is, if you have a very experienced person who's done surgery scheduling, for instance, you're going to be very happy because they'll be used to diverting their attention when needed and getting back to the task at hand. So I would say, first and foremost, hire somebody who is experienced, and someone who can multitask, and someone who can be independent. So I don't micromanage my staff at all. Now, let's say my wife didn't work for us, and let's say that it was completely just people who are unrelated to me, first time in. And really, for the first couple of months, it was like that because we had our son just as we moved into our new office space. So I had 2 folks working for me, one of whom would work for the office before me, and then one who came from a different office. But both had worked in neurosurgery before, and that's really important too. So if you have someone who's experienced, just being experienced is not enough, hopefully within your specialty. So experience is very, very important, not the cheapest. And I think that's the cardinal error a lot of people make. They try to get the cheapest person they possibly can, the least expensive, the person they can, pay $14 or $15 an hour for. Back then, when I was hiring, it wasn't that expensive, but it's gotten more now that you can pay $15 an hour at McDonald's. Why would somebody want to, have the stress and strain of a medical office when they can go to McDonald's, have a shift, and go home and not think about it, and they get fed? So you have to really say you're willing to pony up extra money for someone who can have experience and who can actually work independently. You do not have to micromanage them and show them how to turn on their Mac or how to transfer a call. This has to be someone who is a self-starter, who can really kind of get themselves going and are able to sort of hit the ground running. That's probably the best piece of it. And please, please, please don't be cheap. If you pay for something that's less than stellar, you're going to get something that's less than stellar in return.
This podcast is sponsored by Doc2Doc Lending, the personal lending platform for doctors by doctors. Traditional lenders overestimate the risk of lending to doctors because a lot of us carry significant debt. But at Doc2Doc, they know that as a profession, doctors almost never default on their loans, and they take that in consideration when they're setting our rates. I love what Doc to Doc is doing within our community, so please check them out at doctodoclending.com/PGTD. That's Doc to Doc Lending, number 2/PGTD for Physician's Guide to Doctoring. Yeah, you want to just see patients. That's where you make the money.
You
And
want
the
to see
more you can
patients.
offload to other to someone else, someone
Well,
you trust.
wait, hold
huh?
on a second there, Tonto. Just hold on one second. You
Yeah.
want to just think about this. It's very important that you do keep some skin in the game when you're running your practice.
Okay.
If you're in a small practice, it's very important. Do not lose track of two things: the keys to the mailbox where the checks are delivered and the online password for your credit card. Because what I've seen happen time and time again is people who are embezzled because they didn't track who's spending what on their credit card. They just gave somebody their credit card and they just started to spend. I knew a pain doctor who was embezzled out of hundreds of thousands of dollars by a person who
Wow.
worked for him for 17 years. And then obviously, if someone has keys to the mailbox where the checks go, or the PO box, whatever you prefer, then there's no telling where those checks are. And you may be looking for payment from several very large cases and they never come. And you're calling the insurance company, they tell you, well, we sent it. Where's the check? Right. So you need to maintain some control. And that's the other sort of facet of it, is you have to be responsible still for certain parts. And I think if you start getting to the mindset that, well, I just want to see patients. As a small business owner, you really can't do that because you're immediately handing over the keys to the car to someone else. You have to stay involved. I'm not saying control the whole thing. You're kind of like the captain of the ship rather than the guy who's steering it. You don't want us to be steering the ship. You kind of want to be in the background and say, yeah, I want to go a little bit to the left, maybe a little bit to the right. Just sort of maintain some involvement. Because if you say, I don't want to think about it, I don't want to be involved, that's when problems start happening. That's when your accounts receivable becomes enormous. What the heck is happening? Oh my God.
Got it. So what about expansion, right? At what point do you say, you know what, we're going to need to hire a physician's assistant, we're going to hire a nurse practitioner, or maybe go looking for another partner
Mm-hmm.
or associate, right?
Well, it depends on what your model is. If your model is one where you have a lot of capitation or managed care, getting a physician extender is perhaps a good idea. And when you find yourself working a lot of hours and seeing tons and tons of post-ops that really are just kind of on autopilot, that's generally you want to start looking for a physician extender, nurse practitioner, PA, or even a partner, depending on your model. If you have a model that is very high touch and the patients are very somewhat demanding, and you're in a very large metropolitan area where there's a lot of competition, you really got to focus in on distinguishing yourself amongst the other practices, because they're going to be the ones that have the PAs and the NPs, and they're the ones that see the patients post-op. And it's when patients are having issues post-op is when you get into trouble. So if you're a high touch practice, then it might be that you may need to hire an associate when you find yourself, constantly working, constantly putting out fires. Or you may just say, I don't want an associate, I don't want a PA or a nurse practitioner. I'm going to stay solo and just build relationships with other practices so that I can go out of town, or I can call so-and-so and they'll cover for me. But you obviously have to foster trust amongst your peers to do that, because if you're a guy who operates and then has a massive tonsillar bleed, if you're an ENT, I just say that because that's what my brother does, and so, or if you have a CSF leak, I think you do ear, nose, and throat too, right? You're
Exactly.
So if you have a massive tonsillar bleed and you're just like you're in Curacao and nobody knows about it and you have nobody covering for you, and you say send to the ER, that doesn't foster a lot of trust.
Yeah.
You really got to sort of gain a good reputation in the community if you're going to do that, and have a lot of trust with your competitors / colleagues in order to do that. So it really depends on what your model is, and that's dictated a lot by your geography and your payer mix. So if you're in a large metropolitan area like New York, you may want to just hold up a shingle. And if you have got a great reputation, you handle your post-op complications, and this is the one time you've been out of town for 5 months, 6 months, and something just happens to happen. It does happen. You call your colleague up who's in a different practice, said, "Oh, sure, Brad, no problem. I'll go see that guy. Thanks for the heads up." Rather than just him, the patient showing up at the ER and then calling him and say, "By the way, Dr. So-and-so's patient's here." Who? What? So it depends. I mean, you can do it those three ways. I personally don't have physician extenders. I've chosen not to take a partner on. There's a number of reasons. I think, my model's working. I don't know if it'll always be that way. I don't know if it'll be forever that way, but if you have this dream of what you want to do and you do a good job of it, you should be able to do any of those models would be just fine. And it's hard to know exactly when it's time. I mean, you'll financially know if it's time to hire a partner because he or she will need to take time to ramp up and you may have to support them. And sometimes you have recruitment agreements with hospitals, or you maybe have a private equity backed firm and they're going to pay for it. Or maybe you're a massive group and you have enough money, you can sort of float that person for 2 years and do an income guarantee. But really, at the end of the day, you also have to be prepared for that. They may not be a good fit for your practice. And you may have put on a good face during the interview process and you're like, this is not going to work out. So you have to think about to yourself, well, what if he or she leaves after 6 months or a year? Is it going to devastate us? And if the answer is no, then see what happens.
Yeah. A lot to think about. All right, let's talk a little about just neurosurgery. Okay? Because I have yet to have a neurosurgeon on the show. Every so often we talk about something clinical. And I just have a couple small questions. The first is this overlap between orthopedics and neurosurgeons, right? Both do spine. Now, right? As you said, I'm an otolaryngologist. We do rhinoplasties. Plastic surgeons also do rhinoplasties. And I'm sure the plastic surgeons will say they do a better rhinoplasty, and the otolaryngologist will say, actually, we know more about the nasal airway. We do a better rhinoplasty. But ultimately, it's not like we end at a certain place and they begin. And, we can both do a good job, hopefully.
Sure.
Not sure. Doing it, right? But what about orthopedists and neurosurgeons when it comes to spine? Is there a clinical difference? Like orthopods are not allowed to go into the spinal canal, whereas neurosurgeons are, or is it really you're both kind of there's just overlap there? Like general surgeons, otolaryngologists both do thyroids, right?
Yeah, like a lot of specialties, there is an overlap in between our specialties. For instance, there's the obvious ones like neurosurgeons. We do craniotomies and endonasal pituitary resections, and no one else does, right? No one else does those kind of things. And like you'll never see a neurosurgeon do a hip arthroplasty. It's just not what we do. When we do kind of where the Venn diagram does cross is obviously in spine. And a lot of us do very similar things. In fact, there are some fellowships that are combined ortho and neurosurgery. So you actually have cross-training going on in between specialties. Now, obviously, there's been some
Great.
Yeah, it's very congenial. But there's been a paper or two that sort of says the complication rate may be lower among neurosurgeons. I don't really throw infusion, but I don't throw that in my colleagues' face because I have ortho spine surgeons who I respect tremendously, who I collaborate with and work with and have the utmost respect for. Especially when it comes to deformity surgery. I think the ortho surgeons are definitely ahead of us in terms of scoliosis, the way they've thought about it just for decades. And neurosurgeons are kind of late to the party. One of the big things, though, is obviously intradural work, right? So intramedullary spinal cord tumors, so tumors within the substance of the spinal cord, spinal schwannomas, neurofibromas, those kind of things are sort of really solely the purview of the neurosurgeon, intradural work. So we really generally discourage orthopedic surgeons from doing that sort of work. I'm sure there may be one or two in the country that might argue that they can do it and it's their right to do it. Like Ian Malcolm said in Jurassic Park, just because you can do something doesn't mean you should do it, right? So, I mean, I could clip an aneurysm, but I choose not to because I haven't clipped an aneurysm over 12 years. It says right in my certificate that I'm allowed to, but I just think it's not the right thing for the patient. So that's kind of how I go by guidance. And we, since, on a slightly different topic, as if you're in a big academic center, then there's obviously going to be crisscross between ortho and neuro. There's sometimes competition. If you're out in the community as a private practice person, you're going to get, you'll be the second, third, or fourth opinion. A lot of these patients will be doctor shopping. And I'll get this question: what's the difference between an orthopedic and a neurosurgeon doing spine? And I just talk very briefly about what our training is, and we're doing spine pretty much from the beginning, from year 1 to year 7, we're doing spine. Ortho kind of does a lot of stuff. They have very intensive spinal sections, and they oftentimes will do a fellowship. I chose to do a fellowship because I really wanted to do more complex things. But I would say there's equally good and equally bad both ortho and neurosurgeons. But I think it's more the discernment that really separates good spine surgeons. That means ortho or neuro from bad ones. And I think we all should know what our limits are, what our expertise is, and what our obviously, unfortunate things can happen during surgery, and we all have complications. But obviously, if you feel comfortable doing something and you're good at it, then there's not a problem. And sometimes, complications happen during surgery, and if you're good at something, that's not to say it never does. But I would say if the patient's comfortable with the spine surgeon, whether it be ortho or neuro, that's what I tell patients are most important. Do you trust the person? Because this is the beginning of a relationship. You're going to have surgery. There's a recovery period. God willing, everything goes fine. Just be comfortable with that person, whether he or she's an orthopedic surgeon or a neurosurgeon. I obviously have my preferences, but I have equal respect for them. I think if you're discerning, you're careful, you do a good job, I think it's pretty much up to the patient who they think is going to be best.
You had mentioned a surgery center.
Mm-hmm.
What does a neurosurgeon do at a surgery? Like, I do a lot of my tonsils there and tubes, and I'm sure your
Yeah.
brother does the same, right?
Yeah.
Septum, sinus surgery, and all
Yeah.
these people are going home the same day.
Right. Well, believe it or not, 15 years ago, I'd have been like, you got to be, we have no business in a surgery center, other stuff that we do. But when you start thinking about the smaller things we do, for instance, a single level cervical disc fusion or disc replacement, we do the anterior ACDFs. I just did one on Friday and she went home, 4 hours after surgery. She's doing well, thank goodness. Those kind of surgeries, especially things like kyphoplasties where we inject cement, or we do spinal cord stimulators where we implant an electronic device to reduce pain. Lumbar laminectomies or laminotomies or microdiscs. A lot of those are being done outpatient. And there are people who are sort of pushing the envelope, doing anterior lumbar fusions and disc replacements in the surgery centers and are doing a good job of it. So it depends what the surgeon's comfort level is. Obviously, we can do things outpatient. So far, we haven't done outpatient brain surgery yet, but there has been one or two papers about outpatient brain biopsies, which I don't think I'd ever do. But if you're thinking that the person is young or they're robust and you can do something small for them and it's very safe for them to go home, we do things like cervical arthroplasty or lumbar arthroplasty or microdiscs. Those can be done in a surgery center, definitely, or battery swaps for spinal cord stimulators, even putting in a battery swap. So obviously you want to make sure
there's
you're
no USB
careful.
port.
No, but it's really cool. It's got inductive charging. It's pretty awesome. I don't know if you've ever seen one of those things. They're pretty rad. The main thing is, so again, discernment, like judgment. If you have an 82-year-old person you're doing an anterior cervical fusion on, well, obviously that's not a person you want to go to a surgery center because they could have dysphagia or a number of things can go wrong. But you just want to use good judgment. And I don't recommend jumping right into the surgery center unless you were doing it during your residency or fellowship. If you're cool with it, you do 1 or 2 level disc arthroplasties or disc replacements and you're good at it, you have a good backup for you in terms of a transfer agreement with a nearby hospital. God forbid something happens. But those are things that you can do. But again, things can go wrong, they go sideways, not for anyone's fault, but just obviously stuff happens. But it's important that you do good jobs and you're careful during the surgery center and you're providing value to the patient, to the center, of course.
So for this next question, it might get a little dicey, little controversial.
Okay.
So
Sure.
correct me if I'm wrong at any point, but if someone has an injury at work, right? They end up with back pain. They consult with a personal injury attorney, right? The personal injury attorney would have them assessed by potentially a spine surgeon, possibly neurosurgery, possibly orthopedics. And if there is a lawsuit and the injury is severe enough that it necessitates surgery, then the compensation for that lawsuit is going to be significantly more. Clearly, if I got better with physical therapy is much different than I required a spinal fusion or a laminectomy, whatever the surgery might be, right? So it sets up this conflict of interest such that certain personal injury attorneys might end up referring their cases to someone who's more likely to operate. And it becomes this cycle of conflict of interest on top of the fact that the compensation from commercial insurance is significantly less than the compensation from workman's comp. So there's a conflict of interest on the part of the surgeon. In fact, there are some surgeons who don't take commercial insurance, who get the bulk of their income from workman's comp. So it's this cycle that is just fraught with conflict of interest. Am I incorrect in any of that?
No, I think there are potential major conflicts. Workman's comp now in California is being capped, so it's not as lucrative as it used to be. But there are people who do a lot of workman's comp, and they're very good at it in terms of assessing and treating patients and deciding who's surgical and who's not. But there is a lot of potential for over operating or doing things that are maybe somewhat controversial. Nobody ever wants to do, and I don't know a single surgeon who ever wants to do an unnecessary surgery. Now, obviously, we operate every single time to try to get somebody better. That's pretty much without fail. We're all in it to help patients. There are some relationships that become a little bit sort of questionable or controversial, that I think we really, as a specialty and as physicians, we have to be very, very careful of the compensation, of the, I should say, I guess, the inducement of doing things for money. I hope that people, meaning surgeons, are maintaining a very high ethical standard and really trying to focus in on the patients that need surgery. I mean, I think the main thing is looking at it from a different side of the coin. There are patients that are badly hurt at work or injured in automobile accidents, and you also don't want to deny them care. You never want to deny them care. If they need an operation, they need an operation. But the individual surgeon and physicians really have got to maintain a high threshold to operate in those cases, and just make sure that you're always keeping the patient's well-being in the top of your mind, because the last thing you want to do is have someone have surgery and then require more surgery to fix that surgery, and so on and so forth. Obviously, that can happen even if you're operating with the best of intentions, doing a beautiful job and have beautiful films. Sometimes, again, stuff happens, but I think we have to be very careful and cautious when we're in that sphere, because there is a potential for doing too much or operating perhaps a little bit heavy-handedly. But again, every surgeon I know, every physician I know, they always have patients' best interest in mind, and surgery is done on indication. And I hope it's always done on indication for cases like that. I just think patients also have to exercise some judgment as well. If they think something is a little bit maybe too heavy-handed or maybe perhaps a too bit aggressive, they should, or even maybe absolutely will, get a second opinion or even a third opinion from an independent surgeon. That might be a good way to sort of mitigate that as well, in case they're concerned.
But isn't there, particularly in spine, a good amount of subjectivity in terms of the indications for surgery, meaning like the severity of the pain? Now, my wife had a microdiscectomy, I guess it was a year, maybe even 2 years ago. Wow. She was on the couch. She could barely move, and we have 3 young boys, so like lifting and move, she was on a lot of pain and then she's pain free. Like an unbelievable recovery, right? But if you were to take an MRI of my spine, right? I don't have any pain, but I've, spent a fair amount of my youth lifting weights. So my spine might look terrible in certain spots. The corollary for my field would be a deviated septum. I'll look in somebody's nose and it looks awful. I'm like, well, how are you breathing? Fine. How do you breathe out of that nostril? I don't, but I've had it for so long, it just doesn't bother me. Whereas someone else might have a mild deviation and they're like, oh my God, I feel like I'm not getting enough blood to my brain because this is so like, it's just, they're miserable. It's like claustrophobia. And then you operate them and they do great. So the finding, the objective finding doesn't necessarily correlate with the subjective symptom. But when you have this conflict of interest of potential compensation on the part of the patient, right? How do you navigate that where their 3 out of 10 pain is now a 7 out of 10 pain?
Mhm. I think you have to foster trust between the patient and the physician. And I think you have to really counsel the patient. If you think there's a disconnect between the amount of symptoms and their scans, you can always express your concern. Mrs. Smith, Mr. Johnson, I'm concerned about your outcome after surgery. I mean, yes, you have this disc that's degenerated. Yes, you have concordant back pain, but I'm really concerned that if we operate, it may not give you as much relief as I hope it would. And really, you have to foster that going back to training, but also building it through your experience as a surgeon, where you see patients with certain conditions, they may not get better if you operate upon them. There are guidelines out there now for operating on lumbar disc degenerative disease, putting out by our organizations. But that's that. They're guidelines. Really, it's just the clinical acumen of the surgeon. And I think it's really, really important getting back to the basic, even though it's a sort of a relationship fostered by a legal proceeding or something like that. I don't think your fiduciary responsibility ends because it's just a legal thing. You need to maintain that relationship and be honest with the patients. If you, in your heart of hearts, you're not sure that they need the surgery, but the patient really wants surgery, you have to counsel them very, very carefully. And you always want to give them other options, go through the other things. Now, obviously, there are patients who come in, they say, I'm not interested in therapy or I'm not interested in injections. I just want to have the surgery. Well, just so you know, we like to do those things beforehand, but I'm in extreme pain. All right, I understand. But just so you know, you can do those other things. If any point, even up to the moment before we roll back to surgery, you're able to say, you know what, Dr. Gantwerker, I'm not ready to do this. And that's fine. That's okay. I just think surgeons have to maintain that level of trust where the patients feel they can be honest with you, be truthful, and if you're concerned that they're not going to be a good operative candidate, you can always say no as well, and just say, yeah, I'm not seeing that 3-4 disc causing your the back of your heel pain. That doesn't make sense clinically, and it doesn't fit with the dermatomes. I'm just really nervous about doing surgery on you, and I really think we should look at other things. You
Great.
have to be,
Well,
the
yeah.
green light, yellow light, red light. I mean, if you have a flashing red light in the back of your head, then it may be time to say, you know what, I'm going to get one more test, or I'm going to do a flexion extension film, or I'm going to do something else where I just want to set both our minds at ease before we go into surgery and do something like this. And a lot of times surgery, what you're doing is not necessarily reversible.
Yeah. A lot to think about there. A lot to think about. So
A lot of calculus.
we've covered a lot. We've covered a lot in a short period of time. Starting your own practice, ortho versus neurosurgery, conflict of interest in workman's comp. Quite a bit. Any parting words for our physician audience? That anything we haven't covered?
Well, I think, building trust with your patients is going to be your priority. Building trust with your referring doctors is really important. You have to be prepared if things don't go well, to have a frank discussion with the patients. And I just think always take responsibility for both your triumphs and your not so triumphs. And I think that will really set you apart in terms of building your business. And it may take longer. And I think the parting advice I would say, if you're trying to do this on your own or with a small group of trusted physicians, you have to be patient. You have to just build it up. And you have to understand that, you may not get paid as much, or you may not be as famous or be on Dr. Phil or the doctors or something like that. But, patients in the community will ask, well, who would you go to? Or who did you go to? And they'll use your name. And that's how the slow and steady build goes. And I would just say, there's a lot of money to be made in medicine, but please, please, please try to keep your patients, always keep your patients' well-being at top of mind. And if you're not comfortable doing something, tell them that. And sometimes patients will be like, you know what, I appreciate it, but I'm going to go to a different surgeon. And sometimes the surgeries you don't do are the best surgeries, honestly.
I remember one of the mantras from, although it doesn't really apply in your specialty, one of the mantras from, I think it was my general surgery rotation. If you do surgery for pain, you will find it. Uh, so you break it, you buy it. One of those things. So you got to be prepared for all those
Yeah,
outcomes. I think that's great advice. And
yeah.
if you're looking to establish trust with your patients and build better rapport, listen to back episodes of the Physician's Guide to Doctoring, because it's all there to help you be the best physician you can be and foster that relationship. Dr. Brian Gantwerker, thank you. You're clearly a busy guy. Thank you so much for your time.
My pleasure. Take care of yourself, Brad. It was great to see you.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.